Hello everyone, my name is Kim Dalbert and I'm from Sydney at Neuroscience Research Australia. Thank you all for being here today. It's always so lovely to see a big crowd, and also for everyone online, thank you for joining us. It's my pleasure to introduce the Pam Albany Lecture today. As you know, this lecture honours the late Pam Albany. She was a passionate advocate for accident and injury prevention in her various work roles, and she was also the key facilitator for promoting evidence-based practice through the New South Wales Falls Policy, when we still had one, and the Falls Prevention Program and Network. And this year's Pam Albany Lecture is Professor Hylton Menz. And it's really my true honour, true pleasure to introduce Hylton as a 2024 Pam Albany Lecture. Hylton joins us from La Trobe University in Melbourne, and his research has focused on epidemiology and management of foot disorders in older people, with a particular emphasis on osteoarthritis and falls prevention. And Hylton has published over 377 articles, 3 books and 18 book chapters, and his work has been cited over 38,000 times. So, you know, he's also won lots of awards for both his research but also his outreach. And his textbook on foot problems in older people, Assessment and Management, won the British Medical Association Book Award. So if you want to have a nice reading, you can order that book. Anyway, I think we can all agree that he's pretty amazing. So please join me in welcoming Hylton to the stage.
So thanks very much, Kim, for that introduction, and thanks everyone for coming along. It's a real privilege for me to stand up in front of you here, mostly because Pam Albany did some fantastic work focusing on injury prevention, so I feel very privileged to present this lecture in her name. Now, what I've been asked to talk about is feet, footwear and falls in older people. Now, this is a particular research interest of mine because I have a background in clinical podiatry, so I'm a podiatrist originally, but I also did my PhD under Stephen Lord back in 2002. Okay, so I have an interest in podiatry and also an interest in falls and balance. So what I thought we'd talk about today is really looking at 3 different areas. So we're going to talk about foot problems and falls in older people. Then we'll talk about footwear and falls in older people. And then finally, can we actually do anything about these things with podiatry as an intervention? So we'll talk about the trials that have been conducted on podiatry for falls prevention as well. Now, as we all know, we really can't do much about our feet. We have to use them, okay? So the foot plays a really important role in all sorts of weight-bearing tasks. So everything that we do, whenever we're standing or wherever we're sort of transferring from one place to another, it all gets transmitted through our feet. Now, unfortunately, as we get older, there are characteristic changes that take place to foot structure and function, which makes it far more likely that we'll develop a foot problem. Okay, now we know from studies that have been done that about 1 in 3 people over the age of 65 will develop a foot problem. We also know that there is reasonably good evidence that foot problems are associated with impaired balance and also with problems with gait. But the bigger question is whether foot problems actually increase the risk of falling. So is it sort of pronounced enough that not only it affects balance, but it also increases the risk of falls? So to address this, we first of all conducted a systematic review. Now, this was published back in 2018. There's been a couple of papers that have been published since, which haven't really changed the picture too much. So this is fairly accurate information. So this just shows the sort of databases that we used. We basically did everything we could to try and find all the studies that have been done to link foot problems to falls. Okay, so the only limitation that we had was really a limitation on the English language. Now, the main inclusion was that we focused predominantly on community dwelling older people, so we didn't look at residential aged care, so you need to keep that in mind. We looked at people over the age of 65, any study that had assessed or documented a foot problem, including both cross-sectional studies and also prospective studies that included falls as an outcome measure. Now, one thing we didn't do was that we excluded papers where they looked at specific conditions. So there's a number of studies that have looked at, for example, diabetic peripheral neuropathy, so everybody had to have neuropathy to get into the study. There's also 2 or 3 studies that are specific to rheumatoid arthritis. So we excluded those basically because we wanted to make sure that we were looking at a sort of fairly general group of older people. Now, I had a look at the quality assessment of these studies using an NIH tool, scored out of 9 for cross-sectional studies and out of 11 for prospective studies. Okay, so this just shows you the number of papers that we found and the sort of things that they looked at. So we had 9 prospective studies and 5 cross-sectional studies. And you can see there that the most common thing that they looked at was foot pain, followed by foot problems and foot disorders. There were less papers on sensation, posture, strength, function, and range of motion. Now, I've put both problems and disorders in quotes, and that's because that's the terminology that the actual papers used, but there are some problems with how they were actually defined. Okay, so this shows the quality assessment that we did. So each of the different studies, the 15 studies, are sort of listed vertically, and each of the different questions from the quality assessment tool is horizontal, and we have the actual score overall expressed as a percentage on the right-hand side. Now, what I'll get you to focus on, though, is questions 8 and 9. Okay, so they weren't answered particularly well. And question 8 relates specifically to whether there was actually a continuous measure of the risk factor. A lot of these studies were dichotomous, so does this person have foot problems, yes or no? And question 9 was all about case definitions. Were these things clearly defined? And what we found was that the literature was a little bit patchy in this regard, but we didn't have very clear case definitions for this sort of data. Okay, so this slide here just shows you the effect sizes. So the darker colour represents a stronger effect size, so a stronger link between the risk factor and falls as the outcome. And as you can see there, the foot pain, foot disorders and foot problems had probably the strongest effect size, followed by the rest of the variables, foot strength, range of motion, function and foot posture. So the thing that came through time and time again was foot pain. Okay, so we were able to do a meta-analysis. So this is where you pool the results of individual studies for 3 different variables. So they were foot pain, hallux valgus, which is commonly referred to as bunions, and lesser toe deformity, which includes things like hammer toes and claw toes. So first of all, for foot pain, we had 5 different studies that defined it in a similar sort of way. And you can see there that the odds ratio, once we pull all those studies, was about 1.95. So what that suggests is that you're basically twice as likely to fall if you've got foot pain compared to people who don't have foot pain. The next one is hallux valgus or bunions. We had 3 studies that define this in a similar sort of way. And you can see that the pooled odds ratio there is 1.89. So again, it's around about a 2-fold increase in the risk of falling if you do have hallux valgus compared to not having it. And then finally, lesser toe deformity, so hammer toes or claw toes, or overlapping toes, basically anything. There was 2 studies that looked at that, and the pooled odds ratio there was 1.67. So what we found was 15 different studies, generally pretty good methodological quality, although there were those 2 issues that we talked about related to how well defined these variables were. If we look at individual studies, so single studies, we find that older people who fall tend to have reduced ankle dorsiflexion range of motion, decreased toe plantar flexion strength, impaired tactile sensitivity, and increased plantar pressures. But the three variables that came through from the meta-analyses that have been looked at a lot are foot pain, hallux valgus, and lesser toe deformity. So they're probably the three that we need to focus on. So essentially what this study has shown us is that there is a link between foot problems and falls. In particular, it's particularly strong for foot pain, hallux valgus, and lesser toe deformity. So the next thing I wanted to cover was the link between footwear and falls in older people. Now this is a little bit more tricky. So it's an inherently difficult area to research for a range of different reasons, which I've just listed a few of them there. So there's a lot of different footwear features. So shoes consist of features which might be beneficial or might be detrimental. There's a whole range of factors there. So you can't just compare one shoe to another. You really need to look at the individual feature. The other issue is that we traverse a lot of different surfaces during the day. So we get up in the morning, we might walk on tiles, we might walk on lino, we go outside, we walk on grass, we walk on concrete. So we can't really optimise a shoe for a particular surface because we cover lots of different surfaces during the day. And the other thing is that footwear is very much a situational risk factor. And so just because you're wearing a particular shoe at the time of a fall, it doesn't necessarily mean that the shoe caused the fall. Okay, so there's that issue of attribution that we need to consider as well. Now, Jasmine, who presented just before I got here, who's in the audience, she looked at this in a lot more detail than has been done previously. And on the right-hand side, you can see a picture from her thesis, which was published a number of years ago. But you can see there that each of the shoes are identical except for individual features. Okay? So the problems with the literature before Jasmine came along was that a limited range of shoes had actually been tested. The shoes varied by more than one feature, and there was a lot of variation in balance tests. So Jasmine looked at that and said, well, we need to do this in a fairly systematic sort of way. So she published a number of studies looking at individual features. So this is essentially what she found. Now, I know that I'm compressing years and years of hard work into a single slide, so my apologies for that. But you can see that the main thing here is that a high heel is a bad thing, okay? A soft sole is also a bad thing, but the good things seem to be a hard sole and a high heel collar, so a boot versus a shoe. So they're the main findings, okay? So they're the take-home messages that we need to consider. In addition to the work on falls, on footwear and balance, we also have studies that have looked at falls as an outcome. And we know that, again, heel height comes through as a risk factor for falls, a decreased sole contact area, and also being barefoot or wearing socks indoors seems to increase the risk of falling. If you wear slippers inside the home, you're more likely to trip and you're more likely to fracture. Now, slippers are a little bit tricky because there's good slippers and bad slippers, which we'll talk about later. The example that I've given there are probably bad slippers because they're slip-on things that don't have any backing on them at all, okay? Now, one of the real problems with the evidence up to this point is that we are relying on an older person telling us what actually happened with the fall. Now, Steve Rabinovich, whose presentation is later on today, he's not actually here, but his presentation will be provided later on. He actually collected data by installing video cameras in aged care facilities in Canada. Now, he very generously made that available to other researchers through a data sharing platform so they could actually go in and analyse these recordings. So last year we had a look at that, and we were able to work out what sort of shoes people wore in about 75% of the cases. So in some cases it was obscured by furniture or you couldn't really see what sort of shoes they were wearing. Now, of those 75%, we found about 40 falls where we thought that the shoes had something to do with it. Okay, so about 18% of falls. And the thing that really came through strongly was wearing socks indoors. Okay, so on the right-hand side, you can see a fairly complicated diagram called a Sankey plot. But what I want you to focus on is two different things. First of all, we've got three different nodes to that diagram. So we've got the shoes that were worn, followed by the potential shoe-related cause of the fall, plus where they actually fell, which direction. And what I want you to focus on is really the green. So look at the socks, and you can see that socks were worn fairly commonly. They resulted almost exclusively in reduced slip resistance, and then that led to a reduction in slipping backwards, so it led to a reduction in slip resistance. So we think that socks are probably a bad thing to wear in a lino-covered environment because you're more likely to fall backwards. And a good example of that, so this is a video from Steve Rubinovich. You can see there we've got a lady who actually has a slipper on one foot and a sock on the other foot. Okay, so there's already a problem with an asymmetry there, but when we're going from a carpeted area to a lino-covered area, that exaggerates the difference in slip resistance between the two sides. So that was an example of a fall that probably wouldn't have happened if we didn't have that difference between the shoes. But we did find lots and lots of falls where people were wearing socks on lino-covered floors. Okay, so we know that lots of older people wear shoes that we probably wouldn't want them to wear, so they wear suboptimal shoes. And the detrimental features from both balance and fall studies seem to be high heels, slippery soles, thick and soft midsoles, and inadequate fixation, so not having laces, buckles or Velcro, just slip-on shoes. Whereas beneficial features seem to be a low heel, laces, a firm thin sole, and a high heel collar. So we do need further research to tease these out in more detail, because a lot of these recommendations are very much common sense recommendations rather than evidence-based recommendations. Now, for those of you who are interested, who want to actually look at this stuff and hand it out to patients, we do have a website called foothold.org.au, and we do include pictures of what constitutes a safe shoe versus an unsafe shoe. Okay, now one thing I sort of get asked about a lot is what about non-slip socks? Now, there's actually been 2 recent reviews of these. Unfortunately, they didn't find any randomised controlled trials where they compared non-slip socks to normal socks. Now, what they both found was that these socks don't necessarily improve slip resistance, so there's some examples where it doesn't actually make any difference at all. They may harbour bacteria, which is obviously important when you're looking at a hospital environment, and the effect on falls is fairly inconsistent. So the recommendations of these 2 trials are that safe indoor footwear is actually preferable to non-slip socks. Okay, so there's been a lot of interest in sort of commercialising footwear and different interventions, and I've just got some examples of them there. As a result of all this research that's been done. So we have the B shoe up in the top left-hand corner, which has a wheel in the heel, which stops you from falling backwards. We have the Terumo toe-lifting socks from Japan, which help dorsiflex your toes to stop you from tripping on tatami mats. We then have the Balance Pro insole, which has been commercialised by Steve Perry in Canada, and there's a whole range of vibrating insoles, because vibration seems to be a useful thing for balance. Now, each of these ideas are very good ideas, but they do need a lot more study in terms of effectiveness and acceptability to older people. Okay, and I will just point out there's also a shoe called Bala shoe, which has been produced by Zero. So they've looked at all the different evidence that's out there, and they've created a shoe. So you can actually buy this shoe now, and we're in the process of evaluating that shoe to see if it actually offers any real benefits. Okay, so just finally, I wanted to touch on whether podiatry is effective at preventing falls. Now, we did a systematic review of 9 trials, and we're in the process of updating that. So this was published back in 2019. There's been a couple of studies, again, since this was published, but it is still fairly much up to date. So the primary outcome here is falls rate, so the number of falls over time. Unfortunately, people used a lot of different balance tests, so we're unable to pull the results in terms of the secondary outcome data. We had 3 different types of studies. So we had single interventions, we had multifaceted interventions where we looked at podiatry as a package, and we had multifactorial interventions which looked at referring people for podiatry. Okay, so 3 different approaches that have been used. We also looked at the risk of bias for each of these different studies, and the main thing was the lack of blinding. It's very, very difficult to blind people to an intervention which is a physical sort of intervention. Okay, so first of all, with a single component intervention, so this was my study, the main focus of this was foot pain, not really falls, but we just included falls as a secondary outcome measure. But because it was only a 16-week follow-up, we didn't really find anything much. Okay, if anything, the effect on falls was a slight increase in the intervention group, but it wasn't significant. If we look at multifaceted podiatry interventions, so there's been 3 of these, and these are effective. Okay, so we did one in Melbourne. We then rolled that out to the UK in the NHS, much bigger trial, and we also tried to use the same intervention in a residential aged care facility in Scotland. And overall, we've got a 23% reduction in falls, and that's after people have received routine podiatry, footwear advice and provision, foot exercises, and also foot orthoses. Okay, and that slide there just shows you the forest plot, and you can see overall there's a 23% reduction in falls. Now, for the multifactorial interventions, these are a little bit tricky because these are studies where they did a whole range of things, but they included podiatry as a referral. So we're not sure exactly what happened as a result of that referral. We're not sure exactly what people received. But there's been 3 trials. Follow-up was over 6 months, and they resulted in about a 27% reduction in falls. Okay, so that just shows those 3 studies, overall, when we pull them, about a 27% reduction. Okay, so this was the first systematic review and meta-analysis of podiatry and falls prevention. From 9 different studies, we found a significant reduction in falls. Those that were specifically related to podiatry resulted in about a 23% reduction. Those that included podiatry as a referral resulted in about a 27% reduction. The study quality was generally pretty good, and the main conclusion is that overall we've got a fairly limited base, but it's generally pretty positive, suggesting that podiatry may have a role to play. Okay, so in the future, we do need more trials in residential aged care. There's only been 2, and there's only been a single economic analysis, so we don't really know if podiatry is cost effective. We need to also unpack the podiatry interventions because they've been presented as a package, so we don't know essentially which bits actually worked, whether we can actually achieve a reduction in falls with a single intervention. And also with the multifactorial interventions, it's a little bit unclear exactly what people have actually got. So we are currently in the process of updating this with some members of the audience here, and we'll have some more data to present to you probably next year. Okay, so just finishing up, what do the guidelines say? So is this consistent with the guidelines? So as you know, there were some fairly thorough guidelines published in Age and Ageing in 2022. They suggested that when you're assessing someone for falls risk, you include foot problems and footwear. When you're managing an older person with a low risk of falling, you need to manage their foot problems. When you're managing someone who's at high risk of falling, you need to manage their foot problems and also inappropriate footwear, which stands to reason. And finally, falls in hospital, there's no robust research evidence for non-slip socks yet. Okay, that could change when we have proper randomised controlled trials. Okay, so just in conclusion, foot problems do increase the risk of falling. So as a rough guide, basically double. Okay, so if you've got any of these things, foot pain, hallux valgus or lesser toe deformity, you're twice as likely to fall compared to someone who doesn't have those. If you are wearing shoes that have high heels or you're wearing socks indoors, that puts you at an elevated risk of falling, so we advise against that. Whereas an elevated collar, so a boot versus a shoe, and a firm sole may actually be beneficial. And then finally, podiatry interventions seem to be effective and reduce around about 23% of falls. Thank you.
Thanks for a great talk. We've got time for a few questions. Does anyone in the audience have a burning question? Come in to the mic. Well, yep.
Can I ask a question?
Yes, you can.
Thanks, Hylton. Great talk. So in the early literature for socks and bare feet were lumped together, I presume because of relatively low numbers.
Yep.
In the more recent literature, has the difference been teased out? And if it hasn't, do you have any views on that?
Yeah, it's a good question. So you're right in that in the early days, we sort of combined barefoot and socks just simply as a statistical sort of thing because we wanted more numbers. It's probably the situation where you need to have a look at the individual requirements of the person because barefoot is actually better than socks in terms of slip resistance, but you've got some people who have sensory loss in their feet and other people who don't. So if your sensation is intact, you're probably better off barefoot inside your house than wearing socks. But if your sensation's probably no good, then you're better off wearing some sort of shoe inside the house. Yep.
Wow. Oh, yeah, Steve has a question. Yoshi?
The issue about hard versus soft.
Yep.
So how hard is hard and how soft is soft? And what's the rationale?
Yes, good question. So there's a standardised way of measuring rubber hardness called Shaw A, and a lot of the running shoes that you get are fairly soft, so around about sort of 15 or so. A hard sole is around about 50 or so. And the reasoning behind it is that a soft sole actually is like a strap-on neuropathy. It sort of dampens the effect that you get from the soles of your feet. So rather than normally getting the sensation going up to your brain telling you where your feet are, you put your feet in these very thick, soft soles, you don't get that same sort of information. So that's the idea behind it. Yep.
Hi, thank you for the good talk. I'm an exercise physiologist and I was just wondering if there's anything that we can do to, as allied health professionals, prevent the foot problems that create the falls risk, or is that just a podiatry concern?
Yeah, the number one sort of risk factor for developing any sort of foot problem is actually BMI, body mass index. So we do know that the rates of foot problems are much, much higher in people who have excess body weight compared to those who don't. So that's tricky. That's a very sort of long-term sort of lifestyle sort of intervention that you need to be aware of. And that's something that we, even as podiatrists, we don't know much about because it's a very difficult thing to address. Having said that, we do a lot of different things like foot orthoses and footwear and exercise and that sort of thing, which anybody can essentially do to try and reduce the symptoms. But in terms of the structural deformity, that is a long-term thing. Yep.
Could I ask a question about people going for surgery and they're getting their hallux valguses fixed up and pain? Are we going to be seeing less problems with falls, do you think, or is that going to be a study in the future?
Yeah, that's a really good question because we don't have any good evidence for that. There's only been one study to show that your actual falls risk is increased straight after you have hallux valgus surgery because your balance is affected and you really shouldn't be walking around anyway. But after you've done that, after you've achieved that, and if it is effective, and it's reduced symptoms, then theoretically you should actually have a reduction in falls afterwards, but no one's really studied that yet. It's a good question.
Can I ask about arch supports? Because sometimes if people have had a change in their foot shape, it's often recommended they have arch supports. Are they always effective, or sometimes can they be detrimental because of the rigidity of them or how they're fixed? And in that case, does it help their balance or not?
Yes, we've recently done a systematic review looking at the effects of different insoles. On balance, pardon the pun, you will actually be better off with an insole compared to not having an insole. But it is one of those things, again, which relies on the individual. So if they come back to you and they say, these insoles are no good, they push me out too far and I feel a little bit unstable, then you probably need to modify them. So it's probably something that's related to the individual needs, but overall, foot orthoses or arch supports seem to be beneficial.
I'll just ask one question from Slido as well, and then we'll wrap up. It's not on there anymore, but one of the questions was, what's the recommendation for people who would have swelling of their feet at the end of the day? Is there anything?
That's a good question. So swelling is a tricky sort of thing, because you will find that if you're buying shoes, you're probably better off to buy them in the morning because your swelling tends to increase during the day. So we would always say to people, if you're getting a new pair of shoes and you have swelling, to do that in the morning first. In terms of actually addressing the swelling, there's a number of compression bandages that you can get, which may actually be beneficial for risk of falling through two things. One, by reducing the swelling, but also just by providing that proprioceptive feedback around the ankle. So compression garments can actually be quite useful. Yep.
Thank you. Join me in thanking Hylton for a great talk. Thank you.